Welcome back for season 5 of
A Couple of Multiples, the reality of dissociative identity disorder.
We are your hosts, Drew,
And Garden System.
a married couple both living with DID. We are here to show the world the reality of navigating life with dissociative identity disorder, provide hope to those living with multiplicity and their supporters, and to help educate mental health professionals so that people can receive a correct diagnosis and appropriate treatment as quickly as possible.
Garden System works as a trauma therapist in Florida.
And Drew works with children and hopes to return to school soon to earn her PsyD.
In the article, Separating Fact from Fiction, an empirical examination of 6 myths about dissociative identity disorder, Brand et al. Sets the record straight on the following myths.
Myth number 1, DID is a fad.
Actually, DID has been recognized by the DSM for over 3 decades, and Brand et al. Discovered 1,339 publications about DID from the year 2000 through 2014.
Myth number 2, DID is primarily diagnosed in North America by DID experts who overdiagnose.
Brand et al. Cites studies on DID from a variety of countries around the world. And studies also show that it takes 6 to 12 years of being treated in the mental health system before one receives a correct diagnosis of DID. And Brand et al. Also discovered that multiple institutions routinely underdiagnose DID.
Myth number 3, DID is rare.
DID has a prevalence rate of 1.5% of the general population, which is higher than schizophrenia, bipolar, OCD, or anorexia.
Myth number 4, DID is an iatrogenic disorder.
There are no studies in any clinical population that support this myth, while Brand et al. Cites studies that show a strong correlation between trauma and dissociation.
Myth number 5, DID is the same as borderline personality disorder.
While there are a lot of similarities in symptoms, these are separate and distinct diagnoses.
Myth number 6, DID treatment is harmful to patients.
Brand et al. Cites studies that demonstrate that DID treatment is helpful across a wide range of clinical outcome measures, including a Norwegian inpatient trauma program that found that dissociated self states must be directly addressed in order to improve amnesia.
Now it's time to honor the voices of those living with dissociative identity disorder and to share their stories with the world. Today's episode is sponsored by Petals of a Rose, a short film about a day in the life of a woman living with dissociative identity disorder.
Petals of a Rose has received international acclaim for being an accurate and respectful depiction of DID, the most common response from DID systems being, "I've never felt so seen."
The film has subtitles available in 13 languages, and audio descriptions are included for the visually impaired.
Petals of a Rose is available to watch for free at www.dylancrumpler.com/watch-petals-of-a-rose. Today's episode is brought to you by
Selves, Therapeutics, PLLC, a mental health practice located in North Carolina, specializing in the treatment of dissociative disorders and trauma. Selves is committed to serving the plural population through the utilization of EMDR, clinical hypnosis, expressive arts therapy, and other evidence-based practices.
Selves was established in 2019 and currently serves North Carolina and Florida. We are committed to extending accessibility and currently accept most commercial insurances, Medicaid, and Medicare.
Welcome back to another enlightening episode with Drew
and Garden System,
a couple of multiples.
The reality of dissociative identity disorder. We are honored to have Dr. David Yeung with us today.
Dr. David Yeung practiced psychiatry in a variety of settings on 3 continents. Engaging in private practice for 40 years, he is retired in 2006. In the beginning of his career, despite his education, training, and qualifications, he was ignorant about DID, MPD. Through years of trial and error, he learned to recognize and treat patients with multiple personalities.
It was a long and a lonely journey of discovery. It is his hope that by sharing his clinical experience through this book series, Engaging Multiple Personalities, Volumes 1 through 4, new generations of therapists will come to understand the importance of correctly diagnosing DID and treating it appropriately.
Welcome, Dr. Young. Thank you so much for taking time to be with us today to have this important discussion. And we have Lyle Weinstein, Dr. Young's editor, publisher, and narrator.
Hi, everybody. Like,
Thank you. We're so glad you're here with us today. So, could you please tell us a little bit about yourself and what led you to write the book series, Engaging Multiple Personalities?
in a very short one sentence, no. No, I was born and brought up in Hong Kong, a British colony in China. And during the Second World War, I spent most of the time hiding in a village. So my school education started in middle school and university in Hong Kong after the war. And after I graduated from Hong Kong University, I continued my training for a couple of years in Hong Kong and in psychiatry. And then I went to London, England, to 2 more years of training. And in 1968, I came to Canada, in Vancouver. And since then, I've been practicing psychiatry until I retired about 22 years ago. So, what else?
And when you came to Canada and you were practicing as a
Yeah,
psychiatrist,
yeah.
you were dealing with some of the residential psychiatric facilities
Uh-uh.
and the emergency psychiatric
Yeah.
facilities before you went into private practice.
Yeah. Actually, I have worked in almost all the branches of psychiatry, like outpatient, inpatient, long stay patient, short stay patient, uh, and so on and so forth. So I have worked in different hospitals, including veteran hospitals, treating patients from veterans from the First World War. First World War, now you hardly see anyone Second World War veterans around you. So that's really quite ancient. So uh, the interesting thing is that during my practice, I met a lot of patients. I had no idea what was wrong. So gradually, out of my own struggle and practice and study, I discovered they were suffering from DID. And I based on my experience and practice to find out, learn from the failures and some successes enough. I collected enough number of patients to write a book, and that resulted in the volume one. And then I continued on because there was so much to talk about. So I kept on volume two and volume three and volume four, and some more in my blog.
So when David retired, he spoke to me that he felt that he had not been trained to relate to DID or see DID at all, because at the time he was educated, he was told that this is such a rare condition that you will never see it in your practice.
Yeah, I want to add that in my board examination in psychiatry, the textbook we use, a 800-page textbook, had only one chapter on neurotic behavior, where we found some mention of hysteria, dissociation, and something suggestive of MPD. And that's it. There was not even a chapter on MPD. And they had a long chapter on schizophrenia and bipolar and all these things, So, so we were taught, that there was no such thing as MPD. I mean, it's just storybook things.
So what David decided was that he was educated by his patients.
Yeah. I learned from my patients. Yeah.
And in order to not lose
Mhm.
the knowledge that they had given him as they were trying to heal.
Mm. And he was quite convinced, and my diagnosis were correct, because when I approached them with the understanding they were suffering from DID, they got better. Some of them got better. So, so the the what is it say? What is it saying? The pie in the pudding.
The proof is in the pudding.
Of course, the proof is in the pudding.
Yes, it is. And unfortunately, nothing has changed. There was like maybe one paragraph in my textbook when I was in grad school about DID. And I think most therapists are still out there struggling, not knowing what to do. So it is such a gift for you to put these books together. And hopefully we can make this change and more attention will be given, especially for therapists who are learning.
And this is why after volume 1 was published, which really are case studies, some successful, some not successful, but to show people the approach that David was using. That's why he wanted to write volume 2. So there would be effectively a kind of manual for therapists who were afraid to treat people with DID or uncomfortable or felt uneducated. So that was the genesis of volume 2. And then the genesis of volume 3 was because in the responses he got from Facebook and from his blog posts, there were many, many people who did not have a therapist, couldn't find a therapist.
Mm.
So volume 3 was created for people who uh, did not have a relationship with a therapist yet, but they still needed help. So that was why volume 3 was put together, and it's structured, if you've been listening to it or reading it, more just like conversations at a coffee shop. So something gentle, and people seem to feel that it's very helpful. So again, this is David's work in preserving what he's learned and trying to pass it on for the benefit of the DID community. So that's what he's been doing, and I've just been helping him for 12 years.
No. And I've been trying to keep informed about what's going on right now in the mental health field. And whenever I see a young doctor, a young psychiatrist, I'll ask them, how many cases of DID have you seen? And I was surprised, most of them say one case or not at all. I mean, even today. Now, DID is such a common condition. It's more common than schizophrenia. It's
Yes, it is.
1.5% of the general population, and it occurs in Turkey, in China, and many other countries, and in Norway and so on. I mean, these are cases that they have reported, they have done studies on these places. So So there you are. This is a really serious issue. The whole world, affecting the whole world. The millions of people suffering without being recognized that they have some problem. So it's like in the old days, when people suffering from pulmonary tuberculosis, they're coughing out blood, and they're suffering. It's just not consumption, just rest. They have no idea what to do. The same situation now in DID.
So effectively, what happened after the publication of the first volume is that the people who read it were almost exclusively those with DID. And then it started to expand to their network of support and on occasion to therapists and psychiatrists. But what the individuals with DID were doing, according to what they've communicated to David, was they would take something from his book or his blog and bring that to their therapist and say, this is kind of what I'm trying to talk about. Not that this is exactly it, but maybe this will give you a guidance about what we're trying to work with here. So whenever David would get a response from a psychiatrist or a therapist, this is what made him really happy, because then he felt like all that information would go to all of their patients that they would meet in the future. And when he said he's reached more people after his retirement than he did practicing, that's how he's looking at it.
Actually, one case I want to add, it was one reader of my book wrote to me and saying that she was a mother of some children, and she talked to a psychiatrist saying that she was hearing voices, and the psychiatrist immediately took her in the hospital and was thinking about taking away her children. And she happened to have read my book, which in chapter 5 there was such a case, a patient suffering from very severe DID, and she got her children back after I was treating her. So she showed the book to the psychiatrist. The psychiatrist read the book and actually let her have her children back. Now that was very gratifying to me, that something is affecting somebody remotely in a village in Wales. Wales is so far away from where I'm living today. So that's an
That's a beautiful story. I am so glad she got her kids back.
Mm.
All right. So you've talked a bit about how you came to work with dissociative identity disorder, but what kept you working with this population?
Well, it's very interesting that I'm not a high-profile psychiatrist in my community, so all the referral goes to all the top psychiatrists, in the community. So I'm not a top psychiatrist. So sometimes I get patients that other psychiatrists don't want to see. They don't want to see, and then they send the patient to me, thinking that, oh, this little guy has time to see this patient. And I actually got a call from uh, a psychiatrist saying that I actually don't believe in DID, but I think you like this kind of patient, so I give him to her, give her to you. So, so I think he just did not want to see. He knew that the patient that he needed to do psychotherapy, and he did not have the patients to do psychotherapy. He just wanted to give medication, and he knows enough. He knew enough that this patient would not get better just taking medication alone. So he just got me to take over the patient. So I took over the patient. It's a DID. So that's the kind of patient that's why I started to have a collection of DID patients.
So when the files would be transferred to David and he would review the files, these were files where the psychiatrist that was treating that individual at the time would note dissociative behaviors, expressions of dissociation, but never would they give a dissociative diagnosis. So, for example, the woman David was referring to, who's in chapter 5, struggled with dissociation. I mean, she had many hundreds of alters, and it was very clear. And there was no dissociative diagnosis. There was a statement that she had dissociative tendencies, and she would dissociate, but no diagnosis, either primary or secondary. So those were ones that people would send to David because he was willing to talk to them.
It's I just want to add, it's really unbelievable that such cases uh actually were found. I was referred to I was referred a patient to see me after she was seen by 5 psychiatrists who just depressed her, just diagnosed her as suffering from depression. 5 psychiatrists. And then when she came to see me, I made the diagnosis of DID the first visit. Because she came to see me with her diary. She just so eager to show me that she was DID. She told me her diary. I don't open the diary. I can make the diagnosis within 1 minute. You know this
Yeah, it's
story.
sad that it's sad that it seems that most psychiatrists won't diagnose DID. I've had nurse practitioners say, "I will not diagnose DID." And I just don't understand other than they just can't give it a pill.
That is often the case because giving a pill or modifying the medication takes very little time and you do your billing and you don't really have to think about it. But one of the things David has expressed many times is that people are often diagnosed with depression that doesn't react to the medication. So they call it treatment resistant depression. Yeah. And in his experience, treatment resistant depression is often because there is a real diagnosis that needs to be made. And, you may really be depressed because there is something going on or there was something going on. And DID is at times, the underlying issue. And giving them antidepressants doesn't address the issue.
So
So
true.
it's like treating the symptom instead of the illness.
Mm.
Sorry, I'll be quiet.
Thank you for sharing. All right. So, what did the field believe about DID when you first got started in your private practice?
When I started psychiatry, the diagnosis was multiple personality disorder. But later on in I think 1994 or something, it was changed to DID, Dissociative Identity Disorder. They they don't want to they want to take away the name, the label of personality, because personality to them is there's only one personality. They're very rigid ideas. There's only one personality, the passport personality. But my the way I look at it is many patients with DID, they really feel these are personalities because they feel that that's me, that's not her. She's not me, she's somebody else, another person. And in some cases, some really behave like a different person. For example, I know somebody who disappear into the community 1 month every year, working as in a different profession. And surely she was acting in a different as a different person. So that's the first thing is a personality is the word closer to some patients' feeling. The second thing is personality is so escape me. I can bring it up later. Oh yes, in treatment it's very important to talk to the identity as if she is a person because you have to engage them to help them. You cannot say I hear a very famous psychiatrist say, if I hear voices, tell them to ignore it. You ignore the voices, they will go. You cannot ignore these voices. You have to pay attention. That's my point. Yeah.
So true.
What
Yes.
Dave,
You have to engage.
yeah, what David, that's part of why he named the series that. But one of the other points that he has made repeatedly is that uh, if you want to find a pathway to help someone, you do it through the engagement because they hold the keys. So to tell them, no, I'm not interested in the keys, how can you help them?
Mm.
So that's the analogy that he has used repeatedly about the benefits of engaging them and the failures that are going to happen if you don't.
Yes, exactly. I mean, all the selves hold little bits of information or sometimes a lot of information. So it's super important. All right. Would you please share either a moment or an interaction with a client that changed how you understand DID?
Yeah, I like to bring up this. It's a traditional, a traditional way of doing psychotherapy is a is a conversation between the client and the therapist. It's totally private, confidential, and just between the client and the therapist. And you don't want to hear from somebody else about the client. Don't want to hear. You know, that's a very traditional way of the psychotherapist. But in treating DID, I pay a lot of attention to the significant others. What I got a lot of very useful information because a significant other spend much more time with the patient than I do. I spend an hour with the patient a week, but a significant other is 24 hours, right? So one very dramatic case was the first time I got it. Who is this? It is a DID. Was when the husband told me suddenly my wife became a 4-year-old girl crying in bed, shrinking away from me. And I said, "What's wrong?" And she said, "Don't hug me, don't hug me." So actually, that was the first time the frightened alter came out, and he told me about this. So I realized, okay, it must be the idea, That's the only explanation. I mean, how would someone's wife suddenly become a 4-year-old in bed? That's the only time that she would come out. So
And
yeah,
he also told you that he could bring her out
yeah, you want to,
using certain words. Like,
oh yeah, 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 mm, yeah, yeah. And another patient is, the husband told me that when he used certain words, trigger words, that bring out an alter. And when you use the word, it's like a magic word, bing, the alter comes out. It's triggered, it's come out. So, so these are the information that are very valuable. You have to listen. There's you cannot just say, "Oh, I don't want to listen to anything else. I just want to listen to my patient telling me." That's not good enough. That's all.
Yeah, it's so helpful to hear from the family members what they're witnessing because the client can't always share because they don't remember.
Yeah, without hearing, listening to the family member, you're completely in the dark sometimes, as a therapist. Mm.
Yes. So, how has the understanding of DID changed from when you began to now?
Well, most people get the idea about the idea from the book sequel. Is such a famous movie, uh, famous book converted into a movie, and it was a bestseller for many many years. That's most people got the idea. This is their DID, but actually, in reality, they're not. It is just once in a while you get a picture like this, like Sybil, but the rest they appear in different ways. They appear in very different forms. So so over the years, I just accumulated experience and know that they come in different forms. Yeah, sometimes it's very very different from simple. Yeah.
Yeah, I have a very good friend, Dr. Jamie Merritt, who says if you've met one DID system, you've met one DID system. Like everyone's so unique.
Yeah. Yeah. Maybe the other thing that David has commented on in his blog posts is that when people focus on personality and they think there's this another personality, they miss all of these small parts that might only come out briefly. They might only come out in certain situations, but they're there. And again, this is what he's always spoken about. If you're willing to deeply listen and engage, all of those pieces, as you said, Drew, they have information. They are holding keys that you can use as a psychiatrist or as a therapist to actually benefit and actually support healing. And if you think of it just as multiple personalities, like Three Faces of Eve, where it's like full blown everything, you miss those pieces that are not full blown in that same way with executive functioning. So this is something that David has focused on as well, particularly like in the Therapeutic Guidelines book. You need to relate to these things. They're very important.
Yes, I think that's a really good point. Not all selves or alters are going to be fully developed personalities, for lack of a better word here. Sometimes it's fragments, small pieces. Mhm.
Important, but small pieces.
I think
Right.
therapists really need to focus on the effect of the trauma on today's behavior function. Is those so-called personality or identities are just what appears outwards. But what is really disturbing the person is the total function. If is she able to hold a job? Is she able to look after her children? Things like that.
Right. So, what did mental health professionals get wrong back then that has been corrected, in your opinion?
Well, there's so much more uh, need, so much need to improve the understanding. We as we have been talking, most people just don't know about these intimate details. About the condition of called DID.
One of the things David has written about on this topic, it may sound a little bit strange to start in this way, but uh, when PTSD started being acknowledged, it was not PTSD for children who had been abused.
Hmm.
It was PTSD in the wartime veteran situation.
Mhm.
So, as David wrote, you have a community which is supported by all of society, the veterans.
Mm.
So there was a shift there where once that happened, uh, there was a lot of support for the veterans, there's a lot of treatment options for the veteran, and trying to figure out how to work with dissociation, right? Post-traumatic stress disorders, dissociation. And so that bringing dissociation more into the mainstream because of the veteran situation started to enable, from David's point of view, other therapists to look at, okay, well, dissociation is not necessarily so rare, but the issue still remains that people don't like to talk about child abuse. They don't like to acknowledge that child abuse is rampant across cultures, across ethnicities, across economic stratas, because then it might be my doctor or my lawyer or my next door neighbor or my uncle or whoever it might be. And people don't like that. So there's been a slow leakage of positive things about dissociation, I think, starting with the veterans. And now uh, I think David's been very happy that there are online groups, there are podcasts like yours, which are dedicated to supporting those with DID.
Yeah, I think this is very, very important. Yeah. Mm. I might add something that when I started to study psychiatry in the late 1950s. Now, that was a time when psychiatry, for the first time in history, discovered medication that's effective for anxiety, for depression, for bipolar, for many things, for schizophrenia, So, so psychiatry professionals became euphoric, we thought that once and for all, we have discovered the key. We have discovered some drugs to influence the change, to control improve the symptoms of our mental health patients. And that was really quite exciting. But I think the psychiatrists, psychiatric profession have gone overboard in the confidence of use of medication, and suddenly psychotherapy dropped. The people just don't think about psychotherapy. They say, "Oh, talking doesn't work. Talking doesn't work." Just use the right medication. I mean, that I think even today, especially because of pharmaceutical companies are making so much huge profit, they are very, very powerful. They influence psychiatric thinking. And people are still on that, riding on that height, and say, okay, we are going to refine our medication to treat all mental health problems. We don't need to talk. And especially today, people just don't have the patience to talk. You know, pe- People touch things. They want something effective. Yeah, effective. Yeah, so many things are really effective. I mean, for sleeping pills, of course, it's effective. But some you just cannot use medication to help. I mean, there's a limitation when we don't know that there's such a limitation. People don't accept it. People still dreaming that one day we're going to solve all the problem with pills. I don't think it's possible.
I agree with you. I don't think it's possible either. You're lucky to get 15 minutes with a psychiatrist or a nurse practitioner.
Yeah, so it's not just people's ability to speak, it's the therapist's ability to listen.
Yeah.
And you can't listen if you're looking at your watch and I say, okay, I've got 6 minutes, tell me everything. But I would also remind David about the power of psychotherapy with treating DID. In particular, in volume 1, he talks about one of his patients who was hospitalized for months. And when they were released, there was no prognosis of anything positive, but she'd been very suicidal. And then when she went to see David, this is the one who got her children back eventually. Um, the Mental Services Corporation in British Columbia told David that he could not see her as often as he had been seeing her because they were only going to pay for one visit a month.
Yeah. One visit a week.
One visit a week.
Yeah. And then I wrote back to them and say, please check how much money the medical health insurance have spent on this patient in the 12 months before she saw me and the 12 months after she saw me. And the year before she came to see me, she spent 5 months, solid months, in a general hospital to stop her from killing herself. And that's it. They were not doing anything. They were just trying to stop her from killing herself until she said, "Okay, I'm not going to kill myself." So after she came to see me, I stopped all her medication and still getting better. She never went to the emergency. She never had a suicidal attempt. So, so the medical insurance in that case, luckily for me, for the patient, that said, okay, you can see her as much as you want because I'm
Oh,
saving
that's
money.
wonderful.
You- the problem is, and it was effective. So that's an example.
And that individual has not gone back to therapy
Yeah.
and has stayed in touch with David. So
For the next 20 years.
next 20 years.
Mm.
So from the point of view of you know, cost benefit analysis, you can pay for somebody to be in a psychiatric hospital for 5 months, or you can pay, okay, can she see a real psychiatrist 2 times a week, 3 times a week? Well, it's a massive savings.
I mean, I want to add is it doesn't need to be a psychiatrist, you know. A good therapist is a good therapist. You know, I know some very good therapists.
Yes,
And I
advocating for your clients is so important. That's a really good example of it.
I remember listening to that part, and when you got to that part where you wrote the letter and advocated and explained the cost, I remember being like, "Yes," you know? Like, DID clients, they need more than 1 time per week, you know? Most of the clients that I see with DID, I see at least twice a week, at least. So, what do you think mental health professionals are still getting wrong today?
I think we have for that. Uh, I think we need to pay more attention to past trauma, and this is something that we need to be really firmly kept in our mind. You know, when we see a patient. But that's another issue. You know, when you deal with trauma, you cannot just outright now ask what happened to you. You know, I mean, it doesn't work that way. You know, there's a special skill in how to find out past trauma and so on. You know, and number one, I would say I would not deal with trauma like a police writing a police report. I don't want to know the detail, or I don't even ask direct questions. What happened to you? Because when you ask direct questions, you can get a false positive or false negative. False positive answer is that they want to please you, they want to give you the answer you want. False negative is that they truly they don't remember because trauma comes back in symptoms, not not in detail, you know, in words, you know. So that that's we therapists need to really be specially trained in how to deal with trauma. It's a very big field. You know?
David's concern is re-traumatization. If you're investigating as if you were a police officer or something like that, uh, the patient when they come in to see you, that's not going to be helpful. So his approach, as he says repeatedly, is you have to listen. And because his opinion, you can see that they've experienced trauma. That's all you need to know.
Mm.
If they want to tell you this happened or this happened, you need to listen. You need to be empathetic. You need to pay attention, but you don't need to look for details. If you push with the details, you run the risk of ruining a therapeutic
Mm.
alliance and re-traumatizing the patient.
Mm.
So let the patient, when they feel safe, they will say what they need to say.
Well, what I really need to know is how did the trauma affect you today? That's you know what how is your functioning today? So you keep on being forgetful or what? You know you have time loss and so on. You know so see that's the emphasis is on what's happening today, what's it dysfunctioning right now, rather than what exactly happened decades ago. So
So, when you're working with DID, what matters most that therapists typically overlook?
uh, I think we have covered some of that. You know, uh, it's about the past, but the how the past is influencing your function today. And is there the DID, the authors are still suffering from PTSD, and how is that what we need to deal with, and the authors are fighting against each other, like fighting for time, fronting, so for time to take over the time, like if you are working and you need rest at night. And then another author say, "Oh, it's time for me to go out and have fun tonight." So it's very chaotic. Can create a very chaotic life. So I'm trying to get them to work like a team, like functional multiplicity. That is my game, my aim. That you can work together. You can accept each other being in the same body, but you have to work together like a football team. Mm.
So, from a therapeutic point of view, what David has written about is how do you start to bring down the level of hypervigilance to a level of ordinary vigilance? In other words, you don't want to get rid of all vigilance because you need to be able to cross the street safely. But the hypervigilance is what drags you back into triggers and the power of the past dragging you away from the safety of the now. So that's basically the approach that he has expressed that he has taken, because that's really what the problem is. So there's a reason why people with DID are hypervigilant. So you have to actually understand that and acknowledge that. And at the same time, you have to invite them to remain in the present. In other words, right now, right here in his office, nothing bad happened. That happened elsewhere at a different time. So what he has talked about in his therapeutic sessions is saying, okay, well, like if you look out my window, what do you see? You didn't see that when you were 4 years old.
Mhm.
That wasn't out of your window. So it's like coming back to the present time, the present place as a way to sort of kind of titrate down from the re-traumatizing hypervigilance. So the other aspect that has come up in many of his blog posts and in the interchanges back with people who've written him is that a lot of people have this focus on uh, healing being you're no longer having multiple personalities. You are now fused, unified, a unitary being, blah, 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 blah. And that's why he's focusing on functional multiplicity, because he has seen in his practice where people healed and got their situation far better, but then under stress, the parts come out again. So there's a reason why they came out in the first time. There's a reason why they come out under stress. So if you can create a functional multiplicity, as he's talking about, then you start giving all the parts the ability to work together to stay safe in the present. So if you read, his blog posts or you read some of the therapeutic guidelines, that's what he's trying to bring people back to. And if you have a focus on healing means you are a unitary personality in my definition of what a unitary personality is, that's a mistake.
Well, another point is DID patients don't know what is safe. They don't understand how to feel safe. So I have to touch down how to feel safe. So I think, can you sit here and focus on your hands, resting on your lap? Do you feel safe right now? Are you safe? And I asked them to learn this is how feeling safe means. So they should have be taught that. So they have to relearn how it is to feel safe. I think this is really important. So it's not just analyzing all this multiplicity and so on. I mean, that's really not the central issue.
So what he's talked about is in early childhood abuse, your experience of safety
Mm,
is decimated. So telling somebody who is being re-traumatized, you're safe now, don't worry, you're safe now,
mm,
that's not an experience of safety that's going to be helpful. So this is what he's talking about, and when he talks about grounding exercise and things like you have a physical feeling.
yeah. It's really very, very basic, you know. Sometimes it's a physical, it's a very physical thing, you know. I like people to kind of do some running in my office and running on the spot until the pulse rate go up, and then ask them sit down and watch the body calming down, and that's the first lesson of how feeling safe means. That you're settling down, you're feeling comfortable, and I ask them to start learning that, you know. So sometimes I think I almost want to have a yoga mat in my office.
So one of the other things David has talked about that the therapists are not getting right is connected with what he just described. That when you're being re-traumatized, your heart rate goes up, you have a panic attack, all of those things. You can't tell your body stop that.
Mhm.
So what he has suggested from a grounding point of view is you do something that raises your pulse above what the trigger has done.
Yeah.
And then a different part of your nervous system kicks in, and then it settles your body down. So that's the way you regain control of the present moment through your body. So this is what he's talking about when he says you raise your heart rate, you do some exercise, you take a cold shower, your body will trigger the settling quality. And that's something that the therapists, hopefully some therapists are doing more of that. Um, but if you panic as a therapist when your patient panics, and you can't give them a tool that they can practice at home with, that's a problem. So one of the things David's been very emphatic about was saying you do these grounding exercises before you need them. So you're training your body before it needs to put it into action so that when something does trigger you, your body already knows what to do.
So I think therapy can be using very physical means, you know. So that's more powerful than just talking. It's real experience, the experience of feeling safe. And it might take a long time to teach somebody. So this is how you feel when you feel safe.
So
That is
conventionally, you
absolutely
could say,
beautiful.
Mm.
conventionally you could say, when someone doesn't feel safe, you hold them, but you can't
Mhm.
do that as a therapist.
I sometimes I do it physically. I use a cushion. And I push it against the patient's chest, you know. So
Like this.
yeah. So yeah. So
So
I push it against the patient's chest, and that's not invasive, but it's acceptable. I am doing it physically to demonstrate what feeling safe means. Holding back in the with the breathing in and out, a few times, that's very effective. I've done that. I put a pillow and a hand on a on a chiropractor, and he was very, very traumatized, and he started crying. It's very powerful. So I believe in psychotherapy in a very physical terms, but within propriety, there's no break any laws, any rules.
so as the recipient, you feel the pressure, so you're connecting with your body,
Mm.
but it's not his body touching you.
Right.
It's the pillow.
I cannot touch the patient's chest, but through a pillow I can do that.
So he has a big fat bolster that he used to use for them.
Yeah.
That is fantastic. Yes. For those that are not watching on YouTube, so you might want to hop over to YouTube and watch this little piece because he just demonstrated it for us with the pillow, putting it on Lyle's chest here and we pushing. And this is actually something that my own therapist has done where had the pillow and the pushing, and that is powerful. It is powerful.
When you involve the body in this healing process and learning to be safe, it makes that all around connection, you know. It's very important to involve the body and come back into it.
I think it's worth repeating what you said earlier. It's you have to teach clients how to feel safe because they've never felt safe before. They don't know what that is. They don't know what to do with that. It's how do you feel safe?
And for a therapist's point of view, you have to make sure you understand the difference between a conceptual understanding of feeling safe and the physical experience.
Mm.
Right. So, what does effective therapy for clients with DID actually look like over time?
Well, like in chapter 5 in my patient, in the book, the, the book on engaging multiple personalities. Uh, this patient just brought me a letter, brought me some writings every time she came to me, and in it she just read out what she's asking each alter who wants to talk to me write down something, and it's very very moving, and that's how I communicate with them, I say the next time, please, some author who wants to talk to me, write it, on a page and bring it to the office, and then we can talk about it. So that's how I got to relate to each one who needed help. Oh, of course, there were too many authors, actually hundreds of authors, but I never worry about how many. But the one who needed to see me most will come out. And they naturally they arrange it themselves, that was very successful. That's how I work on this patient.
But the other reason you didn't have to treat all the alters,
Right.
what you wrote about, was that you always invited everyone, all of the parts,
Yeah.
to listen,
Yeah.
no matter who he was talking
Yeah.
about, inviting them to listen.
Yeah. Because every time I talk to an author, I I'm aware and let them be aware that I'm talking to everyone. I'm talking to everyone, and I ask them, anyone who wants to talk to me, especially, can bring something next time. So that's how I deal with this patient who told me that she had several hundreds of authors. But I never worry about how many the hundred. So what, I mean, I'm not going to know everyone, but actually they were really real because many years later on, she gave me a card, thank you card, and with all these writing, June, Julie, Audrey, and so on, So I checked on my notes, medical notes, many years ago, and actually the handwriting were corresponding, were real, John, Julie, Audrey, they were all different people with different signatures. So she had a computer mind, She really remember each one has a different character, So I don't think they were faking it. I mean, there's no reason to fake it.
So, what is your approach to pacing in complex trauma work?
Sorry.
Pacing. How do you determine how fast or slow?
Oh yeah, yeah. It's a very important issue. I think the sooner the better. You must remember not to hurry. You cannot hurry up. You just take a step at a time. But I emphasize a lot on what they do internally. I think I try to stimulate the self inner helper. So eventually they will assign an altar to hang another altar. So actually I asked them, encourage them to do that. And they do a lot of work themselves inside, and I just promote this inner helping each other. So,
This was one of the techniques he used to eliminate internal conflict
mm,
with the goal of functional multiplicity, where everyone is working together as a team.
mm,
You can't work together as a team if you don't talk to the other teammates. So the idea was to create a sense of path for that, and respect and appreciation for all of the altars.
mm,
And I know that for many of his patients he wrote about, there were some altars that were very unpleasant to the other altars, so
mm,
to speak. Maybe mean, maybe angry, but there were reasons for that based on what their functions were. But as you begin to eliminate the amnestic barriers, and you begin to encourage that you could talk to this one or just listen, it starts to eliminate the internal negativity. Does that make sense?
Absolutely. Like, I'm reminded of one of my clients, and we were trying to reach some of the altars that weren't really communicating. And we really just did like a visualization of leaving them gifts like hot cocoa. And then next thing you know, they're actually now communicating. So it's like you have to reach out, you have to be kind, and that's what brings everybody together. Hey, friends, it's Garden System here, and we are super excited to announce that we are accepting new clients for those seeking trauma therapy and DID treatment starting in late spring and summer of 2026. Clients must be in Florida. Visit www.mindfulmultiplicity.com for more information and to join the waitlist.
Hi, friends. It's Drew. We want to invite you to come be a part of our private online community, Hearts Multiplied. We have message boards, live moderated chat rooms, and live events where community members get to interact with each other. There are spaces for everyone, whether you have lived experience or are a supporter or are a mental health professional. And you can upgrade to the Hearts Connect spaces for even more live events and a 24/7 live chat room. Visit a couplemultiples.com, click on Hearts Multiplied, and join an informational Zoom meeting to learn more.
Thank you so much for listening to
A couple of multiples. We hope you enjoy the rest of the episode. All right. So, how do you recognize when therapy is moving too fast or too slow?
well, I don't think it can be too slow. Once you get it going, it is autonomy. It's like automatic. They're getting better, because you have to know that a patient, they want to get better. So you just help give them a hint here and there how to get better, and but you don't hurry them up. You say you can take your time, and then they will do it.
But how about the opposite of going too fast? Because you have talked about that
Mm,
when there's too much being provoked.
yeah, right. Well, going too fast includes re-traumatization. You bring up too many things that suddenly they get overwhelmed with memory. So it's not really good for them. I mean, the best thing is to make them feel safe and take the time.
There's one other point that David makes, which is that with his patients, he would leave time at the end of each session for them to just settle down, to do nothing,
Yeah.
so that there was a transition from the intensity of the therapeutic work to going out to re-engage in the world. And I think in your earlier question about what therapists should do or what they should keep in mind is if you have a very intense session where there may be re-traumatization issues or not, and then you just walk out into the world, you still need time to process. And that was often for David's patients,
Yeah.
the last 5 minutes or 10 minutes
Yeah.
of just settling was very, very important.
Yeah. Yeah. I make sure that they have the time to settle down, to kind of round up everything, and then they can leave my office. So I never let a patient leave my office agitated and upset and so on, That's all right.
I 100% agree. So, how do you conceptualize parts, alters, selves after all these years?
But they are separate parts. It's like a fracture of the mind, fractures. And there's different parts, and they are organized differently. In every case, it's different. Is this it can be just a kind of fractured part, a part which is very primitive. It just hold on to an emotion or hold on to one information or something like that, and it can be well developed into an author which is fully functional in her own right, and she can take over, and she say, "I am going to do this," and 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 she could take over and and live for a few hours or few days or for a month. I mean, there are just there are many different forms, So so it's very hard to say, well, this is typical, this is not typical, but everyone is different. That's why it's very hard to psychiatry for psychiatrists to conceptualize this DID issue. DID is not like schizophrenia. Schizophrenia is like this, and it's like this, and everything is very clearly defined, But DID is not, it is all present in different forms, Like a patient of mine had hundreds and hundreds of DID identities, and some of them very clear cut 5 or 10 or something. Mostly they have about 10, 12 in my experience.
David has also talked about that a lot of the alters can be identified in terms of their function, and that can be very helpful. So you may have a protective alter, and it's
Yeah.
very important to identify what they're doing, because and again, that's a way where you start to create the team concept again, because it's good to have a protector. So one of the points in volume 2 in the therapeutic guidelines is to remind therapists that just as they are evaluating the patient is evaluating them.
Yeah.
And if you don't believe that I exist, why would I talk to you?
I actually encourage the authors, the suspicious one, to continue her work because she's important. Has a protective function. So I think I really appreciate you keeping it safe for her. So keep on, watch out. It's fine, but don't get overboard. Getting overboard is not helpful to you. So I remember a patient when therapy was doing very well, and suddenly she came in and gave me a letter, and the letter said, "I've been watching you. What are you doing? Why are you so doing this to to her? To her. It's another author who is very vigilant, who's keeping an eye on, are you doing something bad to her? I'm watching you. So I said, thank you very much for this letter. I know you're watching and it's good. Keep on your vigilance if you feel that it is for her safety. So I'm doing my best, and I'm glad that you are around, keeping an eye on me. So that's fine. No offense. So that's good.
But that's also different than what some therapists or psychiatrists feel. It's like, you have to trust me. If you don't trust me, we can't work together.
Right.
This is not that. This is saying, you're there for a reason and keep doing your function because it's important. So again, this is again goes back to the earlier questions about what therapists might miss or not miss, or what should be emphasized or not emphasized. And again, that's why David wrote volume 2, to try to collect these kinds of guidances.
We resonate with all of this so much. So we have a 4-year-old alter named Jenny who is very much a gatekeeper and protector of our system. And whenever we were with, like, say, a new psychiatrist or a new hospital visit, she was always like the first one to be out and fronting. And she was the watcher. She would watch everybody, she observed everybody. And it took us a long time to realize that she was the key. Like, if she didn't trust who we were working with, like, no work was going to happen. We had to work with her. And it was hard because she was 4. And so most people didn't want to deal with her. They didn't want to talk to her. But her view was, if you don't talk to me, you don't talk to anybody.
Yeah.
I well, I just remember one time I was talking to my colleague and I said, "What happened? What would you do if your patient suddenly sit down on the floor?" And I mean, I had a patient. I just handed her a doll, and she looked at it and she just sitting down on the floor and acting like a child. So I asked my colleague, "What would you have done?" And he said, "Oh, well, the patient was a 40-year-old professional woman. Well, I will ask her to go back to her chair and behaving her age, her status. Uh, I, said- I said to myself, I mean, you just lost a moment of connection with your patient. I mean, she came out and to relate to you, and you need to relate to that part. That's an alter. And my colleague just could not change her mind. He was so inflexible. So there you are, and it's very hard to teach, to show some colleagues who are really rigid in their mind. And
You have to be flexible. We have had probably 2 or 3 full hour sessions, like in the very, very beginning of our therapy. This is like almost 8, 9 years ago now, but we would spend the entire hour not talking and just coloring. And, like, we would make our therapist color with us. And we would not be able to do the work that we had done over the years, especially the work we're doing right now, if we had not made that connection in the beginning. It's crucial.
I also wanted to point out something that you brought up, and that's, um, really appreciating the selves, figuring out what their role is, and then showing appreciation to them really helps build trust. I had some really selves that were very skeptical about therapy and stuff, but once the therapist figured out why they were there and said, "I really appreciate you," that was just it changed everything. So I wanted to point that out. That's super important. Mm. Thank you. So what do you wish mental health professionals understood about alters or selves?
so basically, I think mental health professionals really need to be better educated about DRD. It's it's just amazing. I mean, there's so much misunderstanding, and I actually had a colleague, psychiatrist, who wrote to me saying, "I don't want to engage the authors talking to them because in doing so, I would be reinforcing their dissociation." Which so they thought that he 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 thought that he was doing the wrong thing if he engaged the authors, but by encouraging the dissociation. I said, oh, I said to myself, patients, DID patients are like fish swimming in the ocean. You cannot teach them how to swim. You don't need to teach them anything. They know, but they're experts in dissociation. Why do you worry about reinforcing the dissociation? I mean, they got it all wrong. This kind of ideas, I don't know where it comes from.
So actually, you did talk about where it does come from at certain points. You have said that uh, they don't appreciate the life-saving quality of a child who's being abused to be able to
Yes.
dissociate. So you're looking at dissociation as 100% bad,
Yeah, negative thing, right?
but that's what saved their
Mm.
existence.
Yeah, that's why they still survive, because what they went through was really, really traumatizing, very, very serious. Otherwise, they would not have got into this. I mean, it's a brilliant way of surviving. It's very serious trauma.
Well, and as you pointed out, what skill set does an infant or a 2 or 3 or 4-year-old have
Mm,
in the middle of an abuse situation?
mm,
So this is a natural process
mm.
that saved the life. But when it happens repeatedly, as you said, then it becomes the default mode, and then it causes difficulties.
Mhm.
But it does not mean that dissociation per se is bad, because it's not. People dissociate all the time, not necessarily having DID.
But to save themselves,
Yeah,
to survive, they had to dissociate. There was no other way.
and it works.
It absolutely does. I'm reminded of the very first video that I made and posted about DID. And the point was is you have to talk to the alters, you have to talk to the different selves, just like you're saying. My belief is that when we engage, we decrease the dissociation because we're bringing everybody together. When we refuse to speak to the others, when we try to say things, oh, we're indulging, we're encouraging, no, like when you refuse, you create more dissociation because those parts then move farther away. They hide, they pull back, and then we don't have all the parts together. So they're doing the exact opposite when they refuse to engage.
Well, we need to know that among the clients who have DID, they have very different degrees of full consciousness. Some of them have absolutely no idea. It's I am Jane and I'm Jane and that's it. There's no other. They just not deny their Audrey and April and Julie and so on. All these other authors. They don't exist. I exist, but there are cases that they are mutually. They know each other, and sometimes and they are very they're the enemy to each other. Sometimes they blame, A blames B for all the terrible things that happen. So sometimes the blame is so angry, so strong that they will become needless. I mean, the patient who cut himself all the time was actually doing that because one of them got so mad at the idea that he actually hurt hurt the other. And they have under this delusion that I can kill you, but I am still alive. I'm a separate person. I mean, they have this kind of delusion, in some cases. So they some all kinds of ways, they present in all kinds of ways. And psychiatry has to really open our eyes to notice.
I just want to remind everybody of something, which is that in the introduction to all of David's books, he talks about being careful when you read this material that it can be very triggering and you need to be in a supportive situation.
All right. So, would you please explain the difference between integration, final fusion, and functional multiplicity? And how does one determine what is right for them?
Well, my aim is multiple uh, functional multiplicity. That's my aim because I did not purposely try to do a integration, fusion integration, but somebody actually did. But I thought it was very secure fusion. But then it just happened that something happened, and she just broke up again because because that is the mode of problem solving all her life. It's really hard to take it away from her. So if life is full of crises, you never know when the next crisis is. So when it comes, it's so easy to break her up again. So I don't aim for functional fusion. I don't aim for fusion in integration. I personally I don't believe in that possible, but maybe somebody can.
David has written that that's a bias of people who are not DID. That people who are not DID have the bias that fusion is the correct, healthy, sane existence and nothing else is. And even if you look at people, as David has pointed out, they have different voices that they use at home with the kids. They have a different voice that they use on the phone with someone who's calling for them. They have a different voice that they use at the office, maybe a different voice when they're in the restaurant talking to a waiter or a waitress. And, you know, that's okay. That's not a problem. We're not all the same all the time, 24 hours a day. So I think that his experience is really focused on how do you live a decent life, not about what is your idea of what a healthy mind is.
Oh, one point I'd like to bring up. A lot of people resent the diagnosis of DID because they thought that it was the way of making excuses, getting out of the responsibility. So I like to say something about this. I don't think people can use that as an excuse because it's extremely difficult in a court of law to to prove that the defendant did something wrong, but it's done by an alter inside. He is not responsible. So uh, because there will always be a lot of argument from the other camp saying this is fake. God, the idea is controversial. You cannot do that. You cannot prove it. You cannot prove this patient is suffering from DID. That's number one. And number two is, I think there's a very good movie called uh, Primal Fear. This, yeah, there's a movie, a very good movie about somebody who was claimed to be a DID, and he did a very good performance in court, showing that the alter come out to kill somebody and so on. But actually, he was faking it, and it's possible. I can believe it. A good actor can fake it, but I don't think they can use it in the court of law because you just don't have solid evidence to say this is. You cannot say I took the blood and the blood test shows that this is the case. No, there's no such thing to prove.
Let me just distinguish two things here. A criminal action and a civil action are very different in court. And what David's point is that nobody in a civil action has an incentive to lie about having DID. They may not be able to prove it, but they got no incentive to lie about it. It's not like you get a badge of honor that everybody's, oh, yes, okay. Whereas in a criminal matter, like David was just talking about, there's a strong incentive to do it because you can get out of very, very bad prison circumstances and go to a hospital for a while. And you can do all other things that make your life as a prisoner easier. So that's the only situation, and I'm not saying they all are fake, but that's the only situation where there is an actual incentive to say, "Oh, I have DID." I mean, a real strong incentive. So, I think we need to keep those things separate. So, you're not going to say, "Oh, I had DID and I was driving and one of the alters took over, so it's not my fault." Like that's like a civil matter. It's not, nobody's going to do that. It's not helpful. You have no real incentive. But if you're in prison, it's a different issue. So I just want to distinguish those two
But
situations.
I'd like to add that that if a criminal is judged to be insane, not criminally responsible for his act, then he will be sent to a mental hospital for a much longer sentence than a life sentence. Because according to the British, I don't know the American way, but the North American way, but the British way is that you kept in the prison until the lieutenant governor's order or something, So you need two psychiatrists to say, okay, he's safe. Now he will not commit it again. I think nobody in his right mind, no psychiatrist in the right mind can guarantee somebody saying this man will never commit a murder again. I think, I think in reality, this is not possible. Nobody would do that.
Yeah. So essentially, we want to distinguish it so that it's clear that multiplicity, and this is volume 3, living in multiplicity, that's workable. That's not a problem. You can be a very beneficial human being. You can be kind to yourself. You can be kind to others. No problem. Meaning that you don't have to cure something. You're just acting more like as supportive teammates, not a cure in the sense of you were flawed and broken and now you're fixed. Um, so I think again, like what we were talking about with the integration, it's like that's the idea of other people's sense of normalcy, right? So again, normalcy is what you use in a court of law. This is what the expected behavior, blah, blah, blah. So, I think that the emphasis again should be on dissociation as a natural process. When it's repeated due to ongoing abuse, it becomes too heavy-handed and causes problems in one's life right now. So it's kind of undoing that, which is what David was talking about at the very beginning. How is it impacting your life now? And how can we kind of work with things? So
Right, like, it goes back to the understanding that there's only one body, so if one alter does something, everybody has to pay the consequence for that one alter's actions. And so really understanding that and the impact that that has is helpful for that functional multiplicity, and then the reminder too with the things we're talking about here is that the multiplicity is not the pathology. The trauma is the pathology.
absolutely.
Okay, so for someone who is just realizing they may have DID, what would you want them to know?
Someone came to you and they just realized they had DID, what would you want to say to them?
Well, I would say that I would like to help you if you need any help, but just take it one step at a time.
There's a lot of people with DID.
A lot of people have DID. In the general population, you are not alone.
And there's a path to healing.
Yeah, this is a path to healing. Yeah.
Yes.
That's true. You're not alone. Like you said earlier, and I love that you said this earlier, that DID is common. There's a lot of people living with this, and we have figured out how to do it. There's a path. Yes, there is a path.
But one of his misconception is even among mental health in professionals is that DID is rare, DID is controversial, but these are totally wrong. DID is not rare. DID is not controversial. There's definite evidence that DID exists. It's an entity and is a disorder affecting many, many people in the world. Millions. Even in countries that they never heard of the word DID.
Yes, yes, you're not alone. What would you say to someone who doesn't believe their own memories?
Well, memory is a very tricky thing. I mean, I don't believe in memory either. Sometimes I have had negative memory, false negative and false positive. You know, so
Individually, he's not talking about as a therapist, saying individually his own experiences with his own memories. He has had false positives, false negatives in his own experience.
so memory is not just simple, straightforward. Like, oh, I went to lunch with Jane. So with my friend Jane, I had lunch with her this today. I mean, that is so I can remember what did I eat and so on. I mean, memory is very complicated. It's affected by a lot of emotional factors. And famous saying is that the body keeps a score about traumatic memory. Is that the body keeps the score, and what?
Its body keeps the score. That's fine.
Yeah. The memory comes in symptoms, not words. It's not memory is there are different kinds of memory. The implicit memory and explicit memory. Some memory is like how to ride a bicycle. It's hard to put in words exactly what you do when you ride a bicycle, but you just know it's implicit. And then the explicit memory is like yesterday I had lunch with Tom. So that's clear.
I know my response to a client recently when they were like, I'm not really sure this really happened to me. How can I know? How can I believe what I think happened to me? And my response was, the body does not lie. When you're looking at somebody and they're frozen, they're dissociated, they're having a trouble talking, they can't make eye contact, the body doesn't lie.
Right. Yeah.
Well, that's why David was saying he doesn't need the details for therapy. You look at the face, there's the trauma right there. You don't need to know it's because of A or B or C. Like, there it is.
I never asked a patient what exactly did the abuser do to you. What exactly did he do to you? I never asked that. I'm not even interested. I mean, I don't want to know, but I want to know how is it affecting you today. That is the most important issue.
Here's an example. I'm sorry. Here's an example from a slightly different context. Um, like, why, if you don't trust your memory, do you trust your gut? Things like that. But a little bit about my background. If you go to law school, at some point in an evidence class, somebody will run in, scream, run all the way around, and leave. And the professor will then look out and say, okay, what were they wearing? How tall were they?
Right.
Did they have a tie? Was it a man? Was it a woman? Were they short? Were they tall? Were they fat? Were they skinny? And everyone gets it wrong. They get a few things right, and a lot of things wrong. And if you look at it, it's not the same as being abused, but it's a shock to your system when this person comes in running and screaming in the classroom. And what happens with your memory? You grab some of it's right, some of it's wrong, but you can trust your gut that something happened. Something happened that was a stressor or something happened that was traumatic, and that's the point. So you can trust your gut regardless of your memory, regardless of the accuracy of your memory. And the other thing that David has talked about was as a child, he thought his bedroom was really huge.
Yeah.
But if you walk into his bedroom now, it'd probably be like any other kid's small bedroom.
Mm.
So, your memory is colored by lots of different things. And this is why you should avoid as a therapist, in his opinion and in his guidance, looking at the trauma like a police officer or a lawyer deposing someone. That's not the point. That's not going to help heal the person.
Yeah, police officer need to write a legal report, report of the incident. So it has to be very clear in terms of black and white, But I'm not interested in exactly what happened. I'm interested in how did it affect you, your body, Sometimes persons just remember a smell or a reflection on the ceiling when something happened, So they don't remember exactly what happened. So our memory comes in very different ways, It's not the usual way of memory as we know the word memory means.
Very good. Thank you. So, what would you say to mental health professionals struggling to understand and or believe the traumas clients share, particularly in regards to ritual abuse, mind control, and organized abuse?
Yeah, people started to be very obsessed about whether it's true or not that ritual abuse could ever happen, and there's a big fight, and people always, the lawyers always brought that out and saying that these are delusion, crazy thinking, But this, I never this regard the ritual abuse is a possibility. I regard it as a possibility. I never say it is not. I have my reason for that because I have a few patients who gave me the experience, which is very close to ritual abuse. It's a kind of mind control, frightening, some using ritual to frighten the person. So I see a lot of reason what they are doing that, and actually I can bring up a point. This idea of a ritual abuse actually started from a psychiatrist who wrote a book called Michelle Remembers in Victoria, Vancouver, uh, Victoria, Canada, in
British Columbia.
British Columbia. I think that was about 1980 or something like that. But I remember that since then everybody started talking about ritual abuse, and they actually, a lot of patients told me that Victoria, the city of Victoria, was actually a lot of ritual abuse groups were going on. It's just grow and grow and grow. But I had a patient before that. It goes back to 1940s in England, and she told me actually there was she underwent ritual abuse phenomenon in a group of Druids. Now that was way, way, way before all these preoccupation about ritual abuse. So there's a lot of things that we don't know, unknown mysteries, and
But
I will not rule out that possibility.
but it's the same basic principle if you're treating somebody from David's guidance, whether it was ritual or non-ritual. the trauma happened.
Yeah.
That's the point. And how do you work with the trauma?
Yeah.
But I would want to remind you about one thing, which is because I think this is a positive aspect, is that David has written many times about invoking positive rituals for your healing.
Yeah.
So maybe you could talk a little bit
But
about like journaling.
yeah, there's a positive side of rituals. I encourage patients to do some positive rituals, like journaling or like going out for a walk and learning how to feel safe and things like that. I mean that ritual is something that you develop into a repetitive behavior, and then you can gain some benefit from it. So journal writing is a kind of ritual too.
Actually, David laid out the ritual that he was talking about for writing a journal, which is you have a pen, you have your journal book. It is only that pen that you use. It is only that journal. You write at this particular desk. You open it, you write, you close it, you put away the pen, everything goes in the proper place. And then after that, you can do some grounding exercises. But if you do that on again and again and again, what you are doing is you then invoke that ritual quality from the point of view of protection. And I think it's important, as David said, yes, there's all this stuff about ritual abuse, but there's a reason why ritual has been around in humanity for, millennia.
Ritual can be positive, it can be negative. I emphasize on the positive side of ritual. We can make use of that.
So that's something that you can begin to develop in your own control.
Yeah.
As opposed to ritual being controlled by others.
I love that. I think that's absolutely amazing. Those are things that I know that I have encouraged clients to do, but I never called it a ritual. And I think that's a really beautiful way to reframe. I like the phrase corrective reparative experiences. So I see how this could be a corrective reparative experience around the idea of ritual and control. I like it.
I think there's a lot of hope in that. So, after all the people you have worked with, what gives you the most hope?
Well, the word is survivor. People can go through terrible, terrible experiences and they survive. People really have this. Don't forget that we all have this survival thing. We can survive, and it's amazing how people can survive very, very overwhelming distress in their life. And especially in babies, I mean, infants, very young child, it's like this, create this something that is we are given by higher power, God, that we can survive, no matter how bad it is. There's such an avenue for survival, and this is what I learned from an amazing thing that people have gone through and they became DID. In fact, better. They can get better too, get more functional, better function.
You also said that the patients that had the best success were the ones that did have angry parts.
Oh, yes. Yeah, I like to emphasize the part of anger, the angry alter. I mean, she's very important because she's the one to protect you. Yeah. Anger is not a bad thing. Or rebellion is not a bad thing. It can be has a very positive aspect to it. Anger gives you the motivation, the supporting love.
So our angry alter is named Maisie, and she's very happy with what was just said. She's like, see? So, looking back over your life, how has this work shaped you as a person?
Well, I learned more about the mystery in life. There's a lot of mystery, and there's more than what meets the eyes. And we have to look deeper and open our mind to deeper things. Is we cannot rely on a simplistic answer, yes and no, and think that we can deal with everything in the world. So
Wait, I
Yeah.
also want to share another private thought that David has expressed is, as he said, he's been retired for about 22 years now. So he's written these books, he's written blogs, he's on Facebook for the DID community, and he gets up in the morning and feels like he's continuing to accomplish benefit for people, as opposed to getting up and saying, where am I going to play golf today? So I
yeah,
think that really, as an outsider, I'm saying that this has shaped how he's lived the last 20 plus years of his life. That there is the possibility, based on what he has learned, to continue to benefit people in ways that he wasn't able to before because he's not just in his little office. So when the books are read and we get responses from Norway or Wales or Australia or the UK or Germany or Russia or, places in South America.
I think I got it from Pakistan.
So this is what makes life, as a retired person,
Yeah.
have value.
I mean, I'm looking back when I was working as a doctor. It's just my learning time. I was learning more than I was giving. I was taking more than giving in my life at that time. And only after I retire and settle down, look at the file and go back and learn what have I done, what have I not done. And then I found out that all the mistake I've made. And then I started learning more, and I wrote a book. And I think that helps more people than when I was working. I'm really kind of disappointed what I was working when I was working. I wasn't doing much. I There's so many cases I missed until now. I look back. Oh, that's the idea. That's obvious.
So again, he wrote the book so that
Well, I was just going to say the reflection is such an important part, and we're so thankful for what you're giving now, Dr. Young, from all the years of it, working with people. It's just amazing.
Right. Thank you.
no, it's like his education said, ignore DID, you're never going to see it. So the first decades of his practice, the term he always uses is, when a patient comes in, you have a certain index of suspicion as to what the potential diagnoses may be. But he was educated to say, don't include DID in that index of suspicion. So the first decades, he's figuring out that, well, no, DID should be in the index of suspicion when you see this, this, and this. So while he's saying he didn't accomplish so much when he was practicing psychiatry, he was learning things that he feels are so important to pass on so that people don't have to practice for 40 years before they figure out, oh, I really should include DID as a potential issue here. So this is why he wrote the books. This is why he's talking on this podcast. So he doesn't want the knowledge that his patients gave him to be wasted.
And this is why we have the podcast. Because, yeah, they're still teaching the same thing. It's 2026, like I was in school in when did I start school? I started school in 2021. I graduated in 2023, and they still taught the same thing. And we have to change that.
I think the world is changing very slowly.
What has working with trauma taught you about humanity?
Well, it's it's not simple. Life is not simple. You get the very best people and you get the very worst people, and they will always be like that. So that's part of life, and we just have to deal with that. You know, uh, evil is always going to be present. Just it's like the other side of goodness.
It's a very sad truth. So, what wisdom feels most important to pass on to the next generation of therapists?
Well, I think as a therapist, we have to step back a little bit and to know that the most important thing is first, you build a therapeutic alliance with your client so that he or she can feel comfortable telling you what is most concerning them, you know. It's, you don't expect them to just come and see you the first time opening the mouth and tell you everything they have been suffering in the past, you know. I mean, that's really quite ridiculous idea. No, this it doesn't happen. You know, people have to feel enough trust to tell you things that really bother them. I mean, that's common sense. And 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 we are now facing a very very powerful kind of opposite trend that people are in such a rush. They want to get quick result by getting a simple medication, and they just always think that medication is going to solve every problem. And this, I think people have to really come to the senses, and this is ridiculous.
So, is there one idea from your books you wish more people truly understood?
I think we have to pay attention to trauma. It's a very essential issue because there are people who say, "Okay, let's forget about the past, focus on the future. Let's not deal with the past." I mean, that's impossible. You cannot deal with the past because you live with the past. The past is always a part of you, and you have to untangle all the terrible things that left you from the past, and you have to handle that so that you can move forward. You cannot keep on being dragged down and say, okay, I'll forget it. It's not like that. Life is not like that. So it's not hard to convince a lot of people. People just have one track mind. It's okay. I just forget about the past and get on to the future. That's fruitful thinking, you know.
I think that's so key. Yeah, our past is a part of us. Yes.
When he was talking about untangling, uh, what he's referring to is saying, um, this is the present, this is where safety is. It doesn't mean the past never happened, but you have to untangle it so that the trigger or memory or whatever the impact is of the past remains in the past. You can identify it like another memory that happened in the past, as opposed to having something come up and drag you back right into the
Right.
bodily re-experiencing of the trauma. So it's untangling it so that thoughts that come in your mind are not re-traumatizing you. So I just wanted to clarify the untangling part of it.
That's perfect. Thank you so much.
So, where can people follow your work and buy your books?
The books are available on Amazon. They are available on Audible as audiobooks. And David has a blog at engagingmultiples.com. And he posts on his blog. He has links to his blog on Facebook. Facebook has, I believe, engaging multiple personalities page. So that's where he continues to post things, even in his 90s, turning 90. And usually what he does is if there's a topic that comes up that's a general topic, because he's been retired, he cannot give psychiatric advice or guidance or things like that. But general things that he feels could be of benefit to the DID community, that's what he tries to write about. So the volume 4 are the collected blog posts from 2014 through either 2022 or 2023. And those are available for free. That's a download from his website. It is downloadable as a searchable ebook or a searchable PDF. So people can use that if they have a question about something. They can get the volume 4 for free, not a problem, and they can search it and use it, whether it's for themselves, whether it's for a family member, whether it's going to their psychiatrist or therapist and saying, what do you think about this? Because this is kind of like what's going on for me. So those are the places. This is the first time David has done anything publicly about his writings or his work, with the exception of one talk he gave at a Healing Together conference, like in 2015, 2014, something like that.
In Florida.
In Florida, yeah. So actually, this is, can you see this?
Yes, we
This
can
is the
see.
book.
Yes.
And this is volume 1. All the books are the same cover picture, which David took. He's actually an excellent photographer. But this is a picture he took of a girls' soccer team.
Yeah.
And working
Sweet.
together. So it's like all the parts working together, you have a team that works.
You just represent the inner family of a multiple. It's just, I just saw the picture. It was so shocked, you know. I saw them playing around in the park, and I took a picture and said, "Wow, there's multiple." Like it's that there are groups of 3 and groups of 2s and so on.
So when we put together the first volume and we were trying to figure out what the cover should look like, David said, "Oh, I took this picture a long time ago. What do you think?" And it seemed perfect. So
Yeah.
so anyway, this is the
I want to add one. I think I really want to bring up Rogers, Carl Rogers. And I want all therapists to be reminded of the most important thing is how follow Carl Rogers' approach, that you need to be genuine, genuine, positive regard, and you have to the same points.
it's in, he did make some notes for this.
Oh yeah. Is the 3 very important points being a therapist is unconditional positive regard. Number 2 is empathy, and number 3 is congruence, like being genuine. So that is like the tripod, the support is solid therapeutic relationship alliance. And that is a very fundamental in all psychotherapy. And I wish they repeat this every year in the medical school. I wish that. This is such an important thing. So that's all I want to say.
There was one more thing that he did want to say, so I'm going to have to say it for him, which is to thank you both for all of your work,
Yes.
supporting the DID community, doing this podcast. It's brave.
Yeah.
And I think that's also important.
And it's very important you can reach a lot of people. I hope this is going to expand really much for 10 times.
Me too.
And and thank you for inviting him
Yeah. Thank you very much.
to actually
Mm.
talk about these things, and hopefully it will continue to benefit. So that's the
We
idea. So I wanted to make sure we thanked you.
Well, thank you. We are so honored to have you. I think you are a wealth of knowledge, and we are so grateful that we are going to be able to share this with our listeners and the wider DID community. It has been quite the adventure to start and do this podcast. We're 2 years in now. And it really kind of got started because I was really anxious after I graduated, waiting for the board to approve me to be a registered intern, and I can't sit still. So we started the podcast so that I had something to keep myself busy with in that time period. So, yeah. Thank you. Thank you so much.
Thank you, Dr.
Okay.
Yeung and Mr. Lyle. What an amazing discussion.
Thank you very much.
Thank you.
Thank you.
So,
Mm.
And thank you, dear
So
listeners, for hanging out with a
A
couple of multiples.
multiples.
Today's episode is sponsored by Petals of a Rose, a short film about a day in the life of a woman living with dissociative identity disorder.
Petals of a Rose has received international acclaim for being an accurate and respectful depiction of DID, the most common response from DID systems being, "I've never felt so seen."
The film has subtitles available in 13 languages, and audio descriptions are included for the visually impaired.
Petals of a Rose is available to watch for free at www.dylancrumpler.com/watch-petals-of-a-rose. Today's episode is brought to you by
Selves, Therapeutics, PLLC, a mental health practice located in North Carolina, specializing in the treatment of dissociative disorders and trauma. Selves is committed to serving the plural population through the utilization of EMDR, clinical hypnosis, expressive arts therapy, and other evidence-based practices.
Selves was established in 2019 and currently serves North Carolina and Florida. We are committed to extending accessibility and currently accept most commercial insurances, Medicaid and Medicare. Thank you, dear friends, for spending time with us today.
We're so grateful for each of you and all the important work you're doing, whether it's supporting others or navigating your own healing journey. We hope this episode brought insight, encouragement, and something new to consider.
And if it did, we'd love for you to share it with a friend, your therapist, psychiatrist, or colleagues. It's one more step toward changing how the world understands DID.
And just a quick reminder, this podcast is for educational purposes only and is not a substitute for therapy. Listening does not create a therapeutic relationship with the hosts or any guest speakers.
And most importantly, remember that every system is different. What works for one may not work for another, and that's okay. Your journey is valid, your healing is real, and we're so glad you're hanging out with
A couple of multiples.